Hello, my name is Joost Boormans. I'm a urologist and heading the Department of Urology at Erasmus MC. Today at Sophia TV, I want to talk to you about our bladder cancer research and the research we are pursuing within the Erasmus MC Urothelial Cancer Research Group. Patients with bladder cancer generally present with hematuria, after which a diagnostic cystoscopy is performed to visualize the bladder from the inside. In case a suspect lesion is observed, patients are scheduled for CT imaging and transurethral resection of the lesion, after which the pathologist reviews the specimen for the presence of malignant tissue. After staging and grading of the tumor, bladder cancer can be classified as being non-muscle invasive versus muscle invasive, depending on the extent of tumor invasion into the bladder wall. High-grade non-muscle invasive bladder cancer is treated with intravesical BCG installations, whereas muscle-invasive bladder cancer requires a multidisciplinary approach, including systemic chemotherapy combined with radiotherapy or radical surgery. Importantly, the majority of hematuria patients do not have bladder cancer, which means that a lot of diagnostic cystoscopies are unnecessarily performed and could be omitted once a non-invasive screening test would be available as a triage tool. For this reason, our group has focused on the development and validation of a urine-based genomic assay to improve current clinical practice for patients with hematuria. This assay includes 6 gene alterations and is going to be evaluated in a large randomized controlled trial within the near future. This randomized controlled trial has been funded by Duos and the Erasmus MC efficiency grant. And our assay will be used as a triage tool for patients presenting with microscopic hematuria. 1,200 patients in total will be randomized into a care as usual arm versus an interventional arm that evaluates the use of our urine test. If the test is positive, patients will undergo diagnostic cystoscopy and CT imaging, but when the test is negative on 2 subsequent occasions, patients will not be further evaluated. For non-muscle invasive bladder cancer, one of the main clinical problems is a substantial failure rate after BCG immunotherapy. More importantly, BCG is not that easy to produce, which has led to an ongoing global BCG shortage. Therefore, we have conducted gene expression profiling and DNA sequencing analysis in order to compare the molecular differences between patients who respond and who do not respond to BCG. As you can see on the right, BCG3 subtype non-muscle invasive bladder cancer patients are indicated by the red line, and they have an unfavorable clinical outcome after BCG therapy. For this reason, these patients may not be ideal candidates for BCG installations and could be prioritized for different treatment regimens. Within this context, the Erasmus MC Urothelial Cancer Research Group has participated in prospective international trials investigating alternative treatment options for BCG, including hyperthermic intravesical therapy and systemic immunotherapy. We anticipate that molecular subtypes of BCG will be useful for patient-tailored clinical decision-making, where the preferred therapy will be based on intrinsic tumor biology. For example, BCG2 subpatients may be most ideal candidates for targeted therapy, whereas the most aggressive BCG3 subtype may be best served by radical surgery or immune modulatory therapy. Muscle-invasive bladder cancer is the most aggressive form of bladder cancer with a 5-year mortality rate of 55%, despite the advocated treatment option, which includes systemic chemotherapy and radical cystectomy. So far, our research has focused on identifying patients that are most likely to respond to perioperative chemotherapy using whole transcriptome and circulating tumor cell profiling. Furthermore, we have also identified potential candidates for chemoradiation, a bladder-sparing treatment option for muscle-invasive bladder cancer. To conclude, within the near future we will put a lot of effort in molecular tumor profiling to identify different types of bladder cancer and to improve clinical decision-making for these patients who have still a very poor outcome. I hope you enjoyed this talk, and if you have any further questions, you can send me an email via j.boormans@erasmusmc.nl.